Thank you for the invitation to speak today. I'm honored to present our experience of the FLS model of care in Toronto and Canada. Many organizations have funded this work, or they have collaborated with us to make the work possible. So I need to acknowledge them, and they include organizations such as Osteoporosis Canada, the PSI Foundation, the Canadian Institutes of Health Research, and the Change Foundation. I especially want to acknowledge the evaluation team in Toronto, and Earl Bogosh and Victoria Elliott Gibson were the founders and are the founders of the FLS in Toronto, and so they get special attention here. I'm a clinical epidemiologist and a phenomenologist, which allows me to examine patient outcomes and patient experiences. I have many research interests, including musculoskeletal health in older adults, the patient perspective, and evidence to care gaps. And I am embedded within two secondary fracture prevention programs in Ontario. One is the fracture prevention program at St. Michael's Hospital, and the other is a fracture screening and prevention program, which is a provincial program that we run in Ontario, and I co-lead the evaluation of that program. I have collaborated with a number of groups, Osteoporosis Canada, for one. I'm a member of the Scientific Advisory Council there, the Ontario Osteoporosis Strategy, the Canadian Osteoporosis Patient Network, and the IOF. And my salary is in part paid by the Ontario Ministry of Health and Long-Term Care. However, I want to say that my views do not necessarily reflect those of the Ministry of Health. So today I want to cover a number of topics. One, I'm going to start with important facts about Canada, and I'll talk about access to BMD testing in Canada and access to medication for fracture prevention, as well as fracture risk assessment tools that we use in the country. I'm going to talk about Osteoporosis Canada's role in FLS implementation, FLS programs in Canada, and then I'm going to move on to FLS programs in Toronto and Ontario, and then I'm going to spend quite a bit of time talking about the evaluation of these programs in Toronto and Ontario. And then I will close by talking about our vision for the future of FLS. So important facts about Canada. We've got about 36 million residents. I think it might be actually about 40 million residents currently. And we have a very low population density. So we've got about 3.9 people per square kilometer. 60% of our population lives in two provinces, Ontario and Quebec. And 60% of our population lives within 100 kilometers of the Canada-US border. In 2017, 30% of the population were over the age of 50, and we know that age is a strong predictor of fracture. And the aging of the Canadian population has important implications for FLS programs. The proportion of the population greater than 65 is expected to double in Ontario by the year 2024. We have a publicly funded healthcare system, which is delivered by 10 provinces and 3 territories. And through the Canada Health Transfer, the federal government provides funds and tax transfers to the provinces and the territories in Canada. However, each province and territory determines what services are medically necessary and what services are covered by their own provincial healthcare system. Fragility fractures are a large group in Canada. We've got over 131,000 per year in Canada, and in the province of Ontario, the number is about 50,000 fragility fractures per year. And the total economic burden in 2010 and 2011 was $4.6 billion for fragility fractures. And that's quite old data, so we know that that number has increased quite dramatically. I think the important thing to note is that 89% of Canadians who fracture do not have access to an FLS. And that's due to a number of reasons, including the population density in the country. The 2010 clinical practice guidelines have general recommendations for BMD testing in the country, as well as they recommend that if you are considered high risk for future fracture, that is an indication for treatment with medication. So I just wanted to point that out before we talk about access to BMD testing and medication in the country. So each province and territory in Canada has its own eligibility criteria for BMD testing. In Ontario, for example, an annual test is funded for patients at high risk of osteoporosis, and this includes those who have a fragility fracture and present with other risk factors. On the other hand, in Alberta, another province in the country, A BMD test is funded for patients who are greater than or equal to the age of 50 every 2 years. So there are differences in the country with access to BMD testing, despite the clinical practice guidelines. We have a number of medications, including alendronate, risedronate, zoledronic acid, denosumab, raloxifene, estrogen, and teriparatide. We also have etidronate as available, but it's rarely prescribed. And again, each province and territory has eligibility criteria for medication that is funded through its own public drug plans. We have two fracture risk assessment tools that are used in Canada. One is the CAROC tool, which classifies individuals as low risk for future fracture, moderate risk, and high risk. And we also use FRAX, which has been validated for Canada, and that's used with or without femoral neck T-score. And this is just a depiction of the CAROC tool that we use. And as you can see, it's been separated into men at the top and women at the bottom. And we've got low risk, moderate risk, and high risk highlighted on the two graphs. And this is the FRAX tool that has been validated for Canada. We don't use it as much in Ontario just because more of the variables that are asked for to complete the FRAX are not captured in many of our databases, such as weight and height. So Osteoporosis Canada has a role in FLS implementation in the country. In 2011, Osteoporosis Canada released a call to action for provincial governments to implement post-fracture care programs to identify and manage Canadians who present with fragility fractures. A number of systematic reviews done by our group and GANDA further shaped the definition of what a post-fracture program was, in that it required a dedicated personnel to run the program, and it also required investigation and or treatment within post-fracture care program. Osteoporosis Canada has a definition of FLS, and they state that FLS is a specific system-based model of care for secondary fracture prevention, where a dedicated coordinator identifies, investigates, and initiates. And so in terms of identification, they define that as systematically and proactively identifying patients aged 50 years and older presenting to a hospital with a new fragility fracture and or with a newly reported vertebral fracture. In terms of investigation, the coordinator organizes appropriate investigations to determine the patient's fracture risk. And in terms of initiation, coordinator must facilitate the initiation of appropriate osteoporosis medications. The FLS must be at least a 2I, which is identification and investigation, or a 3I, which is identification, investigation, and initiation in order to be eligible by Osteoporosis Canada. Osteoporosis Canada also lists 8 essential elements of an FLS, which I will talk about next. And they have an FLS registry, which lists all the Canadian FLS programs who are meeting all 8 of these essential criteria. And I don't expect you to read through the 8 criteria, but I've highlighted that the program must have a dedicated coordinator. It must have a proactive system-wide case finding. It must target at least one of the WHO major osteoporotic fracture types. It must be at least a 2I or a 3I program. It must have a validated fracture risk assessment tool. Medications must be initiated or at least recommended for high-risk patients. It must have some sort of integration with primary care, and data must be collected as part of the FLS program. So as of April 20th, 2021, so just recently, 42 of the FLS programs from Osteoporosis Canada's FLS registry were documented on the Capture the Fracture map of best practice, which was a great accomplishment for us. So I'm not going to talk about FLS programs in Canada, and I'm only going to talk about them briefly because I want to spend most of the time talking about our experience in Ontario. And as you can see, this is the map that shows all the FLS programs in Canada. And where there are circles with a number in the circle, that just means that there are a bunch of FLS programs in that area that are bunched together. And if you can see, for example, in the southern part of Ontario, we've got 23 FLS programs. that are on the FLS registry. And just to note, we do have other programs that are in various phases of applying to the registry. So not all programs that are running currently appear on the map I just showed you. Some of these programs are funded provincially and some are independently funded. And although we have 10 provinces and 3 territories, only 5 provinces actually have an FLS program, and they include British Columbia, Alberta, Ontario, Quebec, and Nova Scotia. And so I'm going to be talking about Ontario for the remainder of this talk. I'm going to start by talking about Toronto specifically, which is the city where I live. There are 2 independently funded FLS programs in Toronto. One is St. Michael's Hospital, which is part of Unity Health Toronto, and the other is the Toronto Western Hospital. And I'm going to be talking about the first of these FLS programs. So the program at St. Michael's Hospital is the longest running FLS in Canada, and it was initiated by the Division of Orthopedic Surgery in 2002 as a quality improvement program. It undergoes regular iterative modifications based on a number of things such as evolving risk assessment tools, evolving treatment guidelines, the performance of the program, as well as qualitative study results. Between 2002 and 2017, so until quite recently, the coordinator of the program was actually employed through an orthopedic research fund. And in 2017, partial funding of the coordinator's salary was provided by the hospital, and this was really a great thing when we found out that the hospital was going to take on part of the payment of the coordinator's salary. In terms of identification, outpatients are identified through the Fracture Clinic list, which is screened daily through the electronic medical records. And we identify men 50 years and older and women 40 years and older. And specifically, we target fractures of the wrist, hip, spine, and shoulder at the St. Mike's Fracture Clinic. Residents and surgeons also introduce the coordinator to the patient, and so that's another way that patients are identified. In terms of inpatients, they are screened through the residence emergency handover list. And so they go through a slightly different pathway. Baseline questionnaire is completed in the Fracture Clinic for outpatients, and this questionnaire is actually mailed to all inpatients. And in terms of inpatients, those who are 65 years and older receive a geriatric bone health assessment. Those who are under the age of 65 receive a rheumatology consult. The specialists order blood work for the inpatients. They initiate treatment where indicated. They make recommendations to the surgeon and the primary care provider, and then the coordinator organizes their follow-up. Standard investigations are carried out for all outpatients at the St. Michael's Fracture Clinic. A BMD is ordered by the coordinator under the surgeon's name, and it's CC'd to the primary care provider, such as a family physician. The coordinator then follows up on all BMD test results and then completes a fracture risk assessment for that patient. Blood work is ordered by the coordinator under the surgeon's name. Again, the coordinator is responsible for the results of the blood work. And as of 2009, a geriatric assessment program and a rheumatologist were dedicated to consult on inpatients at St. Michael's Hospital. And these are the standard investigations that are ordered for all patients. And as I mentioned, the tests are ordered under the orthopedic surgeon's name. However, the coordinator is responsible for the results. And then we do a follow-up questionnaire at 6 months. And in that questionnaire, we gather information on the BMD test scores and the results of the BMD test. A FRAX or a CAROC fracture risk assessment is also conducted and noted, and pharmacotherapy that's prescribed is noted, or if there are contraindications to pharmacotherapy, that's also noted in this follow-up questionnaire. And then any new fractures that have occurred within 6 to 12 months are also noted in the questionnaire. So in terms of the program in general, we see about 350 to 450 patients per year, and 80% of the inpatients are women versus 65% of the outpatients, and 78 years is the mean age for inpatients, whereas the mean age for outpatients is about 65 years old. This program is very research driven. We have an umbrella research ethics approval that allows us to collect baseline information and outcomes, and also to do a chart audit for those who don't complete the questionnaires. And the data that we have collected through the St. Michael's Hospital Fracture Clinic has informed the development of the Ontario Fracture Screening and Prevention Program. And currently, all along, the coordinator at the St. Michael's program has trained all the coordinators for the FSPP, which is the provincial program, and that has continued to current time. The FLS at St. Michael's Hospital was awarded the gold rating of the International Osteoporosis Foundation's Capture the Fracture initiative back in 2016, and that was also a great accomplishment for us. So moving on to the province and the provincial program, I'm going to talk now about the Fracture Screening and Prevention Program, which runs in about 39 clinics in Ontario. And this program was part of the broader Ontario Osteoporosis Strategy, which was announced in 2005. And it was a culmination of 4 years of lobbying. The Ministry of Health and Long-Term Care invited high-volume fracture clinics to participate in this initiative. And they adapted the programs to local and regional situations. For example, not all the clinics have access to BMD testing or access to a specialist. The Ontario Ministry tasked Osteoporosis Canada to lead the operation of the FSPP, which is a provincial program. So Osteoporosis Canada collaborates with the Ontario Orthopedic Association, the Ontario College of Family Physicians, and is currently running the program through 39 fracture clinics across Ontario. The evaluation of the program is conducted by our team at St. Michael's Hospital, and that's co-led by myself and Earl Bogosh, and we have staff, 5 staff members at the moment, and it's a very quality improvement focus. So we have quite a process to place coordinators in the clinics and to accomplish the logistics of this provincial program. Osteoporosis Canada and each hospital enter a contractual agreement, which allows the coordinator to work at each site, and the coordinator has to sign off on confidential agreements with their hospital. The Director of Osteoporosis Canada and regional leads in the province work with hospital management, the surgeons and other specialists, nuclear medicine, and the fracture clinic to make sure that the program is able to run as best as possible given the circumstances of that particular site. The program follows standard screening and data collection protocols. Data is actually collected on tablets, and the coordinators do direct entry into a web-based secure database. We have research ethics approval at each site, as well as at the St. Michael's Hospital site for the evaluation team to do the work that we do. And patient consent is required for use of the data for research purposes. Having 39 sites in this program allows for comparison between the sites, and we screen about 8,000 patients annually, which reflects about 16% of the fracture patients in the province. And the mean age of the patients we see in the fracture screening and prevention program is 67 years, and about 77% of the population screened is women. The care pathway involves a number of steps. First, we identify fracture patients. We deliver education. We do fracture risk assessment, or BMD referral if the patient is not high risk for future fracture at baseline. An orthopedic champion, which is often a surgeon at each site, signs off on the requisitions for the BMD referral. A referral to a specialist is also carried out in patients who are high risk, patients who are considered complex, or patients who are screened while taking bone health medication. Otherwise, they're referred to a primary care provider. Again, the orthopedic surgeon, the orthopedics champion, which is often a surgeon, signs off on those referrals. Referrals to falls preventions and a chronic disease self-management program is also made if the hospital has an available falls prevention, or chronic disease self-management program. We collect data on demographics, including risk factors, such as prior fractures. We collect data on fracture risk status, either at baseline and or after a patient has completed a BMD test. We collect data on treatment status, including prior medication prescriptions. We want to know whether or not patients have visited their primary care physician or the specialist. And this allows us to potentially link our data with administrative data at the provincial level, such as whether or not those BMD tests were completed, whether or not prescriptions were filled for patients who are 65 years and older, and to look at other outcomes such as refracture rates. So I'm going to move on to talk about the evaluation of the programs in Toronto and Ontario, and this mainly involves the work that I do on a daily basis. I think of key importance is cost effectiveness. I'm going to start by talking about cost effectiveness, and a number of reports and manuscripts have been written about the cost effectiveness of our programs, either at the national level, the provincial level, and specifically at the hospital at St. Michael's Hospital. So for one thing, Osteoporosis Canada put out a report on the potential impact of the systematic uptake of FLS on hip fracture costs in Canada. And they said that if all fracture patients in Canada had access to an FLS and they received identification, investigation, and initiation of appropriate pharmacotherapy to lower their risk of fracture, so if all of this happened, 20,000 hip fractures and 10,000 non-hip fractures would be prevented over an 8-year period. 450,000 acute care hospital bed stays would be freed up, and 2,800 to 4,800 long-term care admissions would be averted. In 2008, we conducted a decision analysis model at St. Michael's Hospital from the perspective of the hospital costs. And the results of this analysis was that for a cohort of 500 patients, we found 3 fewer hip fractures and a net hospital cost savings of just over $48,000. And we also reported from this manuscript that the coordinator led to a cost savings if greater than or equal to 350 patients were seen annually. So that was done in 2008. In 2016, we did a cost effectiveness analysis of the provincial program, and it was a Markov model with a lifetime horizon from the perspective of a third-party payer. So in this case, we were looking at the perspective of the Ontario Ministry of Health and Long-Term Care. And from this manuscript, the results were that the FLS improved quality adjusted life years by 4.3 years. It was cost effective at the cost of just over $19,000 per quality gain. And we also looked at a more intense version of the model called the BMD Fast Track, where a BMD test was ordered. And we found that that version of the model, which I'll talk about a little bit later, was even more cost effective at just under $6,000 per quality gained. And more recently, and this study is still in press, we did another cost effectiveness analysis using a slightly different Markov model. So we used a state transition Markov model with a lifetime horizon. And again, it was from the same perspective of the third party pair, which was the Ontario Ministry of Health and Long-Term Care. And the results of this most recent cost effectiveness analysis was that 18 fractures were prevented per 1,000 patients over their lifetime. And this model was actually found that the program was cost saving. So it was $274 less costly than usual care over the lifetime of the patient. I'm going to talk a little bit about improvements in the program based on our evaluation. So the FLS program in the province, the Fracture Screening and Prevention Program, started off mainly as an education-only program. And so the BMD Fast Track was a more intensive version of the program, which included BMD testing, fracture risk assessment, and communication of guidelines to primary care providers. And this was implemented at 6 sites early on in the program. And so in this particular study, we matched cases from the BND Fast Track with controls from usual care in the FSPP based on age, sex, fracture type, and date. And what we found was that patients screened through the BND Fast Track, those 6 sites where the BND test was conducted within the program, showed that the number of BND tests increased from 66% to 96%. The number, or the percentage of visits, I should say the percentage of BND tests increased. The percentage of visits to the primary care provider also increased between the controls and the BND Fast Track sites from 60% to 90%. And medication initiation rate also increased from 16 to 32% in the BND Fast Track. And so this led to the BND Fast Track version of the program being rolled out across all sites. So now that is our usual care in the fracture screening and prevention program. We also did some work around BND tests to improve the reporting of these tests, because what we were finding was that the BND reports were not always reliable. And in one study, we found that greater than 50% of the BND test reports underestimated a patient's fracture risk. So we had reviewed test reports across 9 BND clinics in the Toronto area, and we found that the prevalent or prior fracture had been disregarded by the radiologist as a risk factor in the fracture risk assessment. So we confirmed this finding in the FSPP data, and in 2016, we reported to the ministry that there was a 20% discordance rate that was observed between the fracture risk tools that we were using by the evaluation team and the BND test report itself. So we actually did a study, a quality improvement study to try and decrease that discordance. And so we collaborated with Osteoporosis Canada to implement an online quality improvement question to capture this discrepancy. And this allowed the coordinator to check the BND test results with the radiologist and have that discussion with the radiologist if she felt that there was a discrepancy. And this resulted in a reduction from 20% to 7% of discordance in 2016. And we just recently reran this analysis to confirm that that discordant rate is still around the same. It's about 9% currently, which shows that this discordance in fracture risk calculation has remained consistently low due to our evaluation work. We implemented a specialist track in 2017, and this was partly based on some of the work that I'm going to talk about a little bit later, where we found that specialists appear to be more interested in patients' bone health than their primary care providers. And so the specialist track was implemented in sites in the fracture screening and prevention program that had specialists. So not all the sites have specialists, but for the most part, they have a specialist, or they have access to a specialist. And patients who are referred to a specialist are those who are on bone health medication at the time of screening, those who are automatically considered to be high risk at screening. So those include hip patients, hip fracture patients, patients with a spine fracture or multiple fractures, and patients who have been deemed high risk after they have completed a BMD test are also referred to a specialist through this pathway. Patients can choose, even though we can make the referral, patients can choose to attend their scheduled appointment with a specialist, or they can actually go back to their primary care provider. So we did an analysis in 2021 of patients who were not on bone health medication at the time of screening and referred to a specialist. And we found that medication initiation rates of those who went to the specialist was 77%, as opposed to patients who went to their primary care provider instead. Their medication initiation rates were 33%. So this demonstrates to us that it's really important that patients who are referred to a specialist actually attend that appointment if it's possible, because they are more likely to get a prescription if indicated for one. So let's talk about some other outcomes. Early on, we did an interrupted time series analysis using population-based administrative data. And this was data based on the early years of the program from 2002 to 2010. And what we did here was we compared similar hospitals in the province of Ontario who had an FLS intervention versus hospitals without an FLS intervention. And then within the FLS intervention sites, we subcategorized patients into patients who we knew had actually seen a coordinator versus those who had not. And this is because not all patients see the coordinator, because the coordinators are not all full-time at the individual sites. And so we wanted to see whether or not we could even look at differences within those sites that had an FLS. And what we found was that the BMD rate increased from 17% to just about 21% at intervention sites, whereas there was no change at the control sites once the FLS had been implemented, and that medication initiation rates increased from 21.6% to 24% at intervention sites, whereas there was no change at the control sites. And both of these rates were higher when a patient was confirmed as being screened by the coordinator. And so this is just a graph. It's a very busy graph. I just wanted to point out that considering that the coordinator does not see everyone at the intervention sites, and that this is sort of in the early days of the program when we only had education as our main intervention, we can see that in the intervention sites, the BMD testing increased from 17% to 20.9%. And if you see that arrow that says time 0, that is the start time of the program, the FLS program in Ontario. And so BMD testing increased from before to afterwards, and treatment initiation also increased from 21.6%, which was before the program was implemented, to 24%, which is after the program was implemented. And the green bar shows the patients who were confirmed as being seen by a coordinator at the intervention sites. And so you can see that the number, the rates for BMD testing and the rates for treatment initiation are actually higher in patients who were confirmed as being screened by the coordinator at those sites. So again, this is early days of the program when we didn't really have the BMD fast track implemented, and still it showed that the program had started to have a clear impact. More recently, we looked at medication prescription in hip fracture patients in the provincial program, and the blue bar shows 2017 to 2018 data, the yellow bar shows 2018 to 2019 data, and then the green bar shows provincial data. And you can see that over that 1 year period, medication prescription rates have gone up in hip fracture patients, so from 49.1% to 53.6%. So that is increasing, and we hope to see that increase because hip fracture patients are indicated for medication based on the 2010 Canadian Clinical Practice Guidelines. And both these rates are higher than the medication prescription rate in hip fracture patients across the province in general. And just to point out that the provincial data actually includes sites that have the FLS programs. So it does include the FSPP data as well. We've done some work in equity, and in one study we looked at equity in treatment based on sex. Partly because we know that historically men are less likely to be treated for osteoporosis and fracture prevention, and we wanted to know whether this gap existed in the FSPP. So we looked at patients who were not on medication and screened between 2011 and 2016, and 38% of the men in our study were high risk for future fracture, compared to 47% of the women who were high risk for future fracture, which was not surprising. However, when we looked at all patients who were high risk, we found that the rate of men and women treated with medication was not statistically significantly different. And that was, the rates were 66.2% compared to 68.4% for women. showing that we believe the program is equitable in terms of treating patients based on sex. More recently, we did a similar study looking at equity in treatment based on age. And again, historically, older adults, and for our purposes, we were looking at individuals who were 80 years and older. Historically, these individuals are less likely to be treated, and we wanted to know, does this gap exist in the FSPP as well? Again, we looked at patients who are not on medication, screened between 2017 and 2019 this time, and we found that just about 75% of patients who are 80 years and older were high risk for future fracture, compared to 41.5% of patients who were between the ages of 50 and 79. Again, not surprising that we'd find the older cohort more likely to be high risk for future fracture. However, once we controlled for risk and only looked at patients who are high risk, we found that, again, there was no statistically significant difference in treatment rates between patients who were 80 plus versus patients who were 50 to 79 years old. And so our conclusion is that the program appears to be equitable for treating individuals based on age. And so I'm now going to talk about an area of research which I personally find very fulfilling. And this is about patient perspectives. And, you know, why would we look at patient perspectives? Well, early on in the program, we did some structural equation modeling, and we found that the pathway from BMD testing to medication initiation was actually mediated by patients' perceptions of their need. And perception of need was in itself influenced by self-reported BMD results, or what people thought their BMD results were. And this was looking at patient perceptions from a very narrow view, but it pointed out to us that this kind of work, you know, looking at patient perceptions, was central in the path to treatment initiation, and perhaps is important for a number of other areas. So a special feature of the Ontario FSPP and the St. Michael's Hospital FLS is its unique integration of research on patients' perceptions, attitudes, and behaviors. And so we've looked at a number of things, such as patients' perceptions of the fragility of their bones, their understanding of interventions, their understanding of risk, their interactions with healthcare providers, how they navigate the healthcare system, and their views about using or not using medication. And the list goes on. And really, all of this work on patient perceptions informs the evaluation that we have been conducting since the inception of the program. For example, we try to use language such as fracture prevention rather than using the word osteoporosis, because osteoporosis is seen as a disease of the old and the older person, and it's also been associated as a woman's disease. And so we want to be able to dispel those misconceptions. So one of the studies that we conducted looked at the association of fragility fractures with underlying bone health and whether or not patients made that connection. And I think a major barrier to treatment initiation, and this is including both pharmacological treatment initiation and non-pharmacological treatment initiation, is the failure of patients to connect their fracture to bone health. And in this one study, we found that the term fragility fracture was actually a misnomer. And patients perceived the fracture to be a very traumatic experience, both emotionally and physically. And the fracture was perceived to be a freak or a fluke event. And patients used action-oriented words to describe their fractures. For example, I caught my toe on the edge of the carpet and shot out of a catapult, practically onto the sidewalk. And one 73-year-old female said to us, the elevator did not come level, and I pushed the buggy into that little gap, which is higher, and I flew into the elevator. We've done other studies looking at the burden of fracture and the different elements that make the fracture a burden to individuals' lives. In one study, over 2/3 of patients that we interviewed described fracture-related pain and or limitations at follow-up after their fracture. And in another study, we found that 51% of patients spoke unprompted about post-fracture pain beyond 1 year of the fracture. And 76% of these individuals had sustained a non-vertebral fracture. So in the literature, there's a lot of talk about pain from vertebral fractures, but the patients that we interviewed, most of them did not have a vertebral fracture. And this pain was perceived to be disregarded and untreated by healthcare providers. We've shown that patients become fearful of falling after a fracture, and they monitor their actions with a high degree of vigilance. There's a degree of work described by patients when they're trying to manage their bone health. They talk about non-pharmacological strategies such as exercise and diet. And in one study, we classified individuals as effective consumers based on the intensity of the behaviors that they took on to manage their bone health. And these included making requests to healthcare providers for referrals, to bone specialists for referrals for a BMD test, and specifically asking for prescription medication as well. We have found that men rely on their wives or their female partners to help them with managing their bone health. And in this particular study, we found that men described these women as being integral in their bone health management, in that they did things like help them with their medication regimens, and they removed tripping hazards in their home. We found that informal care needs are an additional burden of fragility factors. Most patients living alone receive no care after their fracture, and we have shown that participants are reluctant to ask for help or to accept help, and they will often devise strategies to manage their bone health, and they prefer to rely on multiple people so as to not burden family members and friends. And these care needs actually affect their fracture recovery and their bone health management. And women specifically appear to need more help with personal daily activities such as bathing and dressing. And most people who talked about needing help with transportation were also women. We have done a number of studies showing that education is not enough, and our program is no longer an education-only program. But even the education that we provide, we have to be considerate of how effective it is at times. We know that patients are uncertain about the cause of the fracture. They are uncertain about the BMD process and test results, and some of them consider evidence of compromised bone health as not accurate or serious. Some patients express uncertainty about the treatment recommendations. They don't know what doses they need to take and how long they have to take it. They'll say things like, you know, if I feel better, maybe I can stop the medication. And these findings that education is not enough definitely support the conclusions of our earlier systematic reviews, showing that interventions that had an education component alone were the least successful in terms of outcomes. We've done some work on medication use, and that includes the uptake or the initiation of medication, as well as persisting with medication. In one study, we found that about half of our patients have difficulty with the decision to take the medication. They're concerned about anticipated side effects or side effects that they've already experienced if they've been on medication for a while. Patients have been found to start, stop, and restart their medication. In one Ontario FLS site, we found that 13% of patients who were on medication at baseline had discontinued that medication within 6 months. And all this sort of points to the message that healthcare providers should periodically check in with patients to determine if their willingness to take that medication has changed. The reliance on fracture risk, the concept of fracture risk, has been also problematic. I think our assumption is that you know, we think that if we relay fracture risk information to patients, that they will learn that level of fracture risk and they will absorb the meaning of it. But this concept is actually difficult for some patients. And so we did one study where we ran an intervention using 3 communication strategies, trying to convey high risk to patients and their healthcare providers. So one of the strategies was to use verbal communication by telling patients verbally that they were high risk for future fracture. We used a numerical prompt telling them that they had a greater than 20% chance of future fracture over the next 10 years. And then we also gave them this graph which highlighted high fracture risk in red at the bottom. And what we found was that patients had very poor recall of the graph. I think 3 of our participants mentioned the graph or remembered the graph. And of those patients who recalled being told that they were high risk, about half of them did not actually believe it applied to them. And patients were also unsure of what they were at risk for. So they told us that they were at risk for osteoporosis, they were at risk for low bone density, they were at risk for falling, for fracturing if they fell, and for fracturing if they fell backwards versus if they fell forwards, and a number of other things were also confusing to them in terms of what they felt they were at risk for after undergoing the intervention. We feel that comorbidities need to be considered, and this is something that we've been looking at more recently. We know that 37% of hip fracture patients have 4 or more comorbidities. And we also know that many chronic health conditions and medications compromise bone health through a number of ways, either through bone loss, through decreased bone density, by increasing fracture risk, by increasing the risk of falls. And so we did interviews with fracture patients who reported 1 or more chronic health conditions at the time of screening. And we found that the awareness of the connection between bone health and their chronic health conditions, such as having type 1 or type 2 diabetes, was very low. And we also found that the awareness of the association between their bone health and the medications they were taking for their chronic health conditions, such as DMARDs, was also very low. We found that depression and chronic non-fracture pain were common in patients with a fragility fracture. And in the study that I just spoke about, that data set, we reanalyzed it looking at pain and depression. We found that 81% of patients with 1 or more comorbidities reported depression and or chronic pain. And this depression and chronic pain, this is chronic non-fracture pain, so it wasn't pain related to the fracture, was described as all-consuming. It was mostly prioritized over bone health, and it actually worsened as a result of the fracture. So for example, when 56-year-old female said to us, bone health is really manageable in a way that depression sometimes doesn't feel manageable. The pain from the fracture isn't as bad as the pain from my back. And this was a 78-year-old female participant, and an 80% female participant said, anything that confines me to the house, and she was talking about the fracture, makes it, my depression, worse. Unfortunately, we can't control what happens outside of the FLS context, and so we've done some work looking at barriers at the healthcare provider level, and we found that some providers, healthcare providers, make clinical judgments about bone health and relay these judgments to their patients, such as telling them that they don't need a B&D test because they are overweight, they're too young, they are too old, or they are from a specific ethnic group. We've found that patients perceive primary care providers as not so interested in their bone health, even when they have presented to their primary care provider with height loss, with a vertebral fracture, with a history of multiple fractures, with a family history of osteoporosis, or they have been deemed high risk on a B&D test report. They have told us that they often find that their primary care provider does not seem so interested in their bone health. And this is what led to this specialist track, which was implemented in 2017 that I discussed earlier on. Patients perceive inconsistent messages about bone health and recommendations within healthcare provider groups and across these groups. And we were specifically looking at the fracture clinic staff, primary care providers, specialists such as our endocrinologists, physiotherapists, nutritionists, and chiropractors. We've also found that fragility factors are associated with an important social role in patients who are caregivers. the fracture can actually occur in the act of caregiving. And in this particular analysis, giving care was prioritized over bone health by participants. And they complained that the fracture itself prevented them from fulfilling their caregiving role. So looking forward, what is the future of FLS? So I'm going to speak really from the perspective of our group, because I don't know really what other groups in Canada are thinking moving forward, but I certainly have a vision for our group to talk about. We really want to continue our work in equity and to look at variables such as race, education status, and socioeconomic status. There's been a lot of literature about the effect of COVID on screening, testing, and treatment, and so we plan to do some analyses on our own data to see what has happened with patients since the fracture clinics have been closed in Ontario. We're interested in the concept of caregiving. Again, this is a topic which is outside the FLS boundary currently, but I think it might be something that we could integrate within FLS programs if we have the resources. And I'm interested in particular in three groups of individuals: patients who need care, patients who are caregivers, and then caregivers of patients themselves. We've been working on targets for treatment for a number of years, and we're continuing to work on what we think should be reachable targets. For example, risk fracture patients versus patients with a hip fracture based on information like contraindications to medication. And so that work is continuing. And we're also currently doing a project looking at applying the FLS concept to a rehabilitation setting. We were fortunate last year to hear the announcement of the Brookfield Chair in Fracture Prevention, which is the first of its kind in Canada, and I believe probably the world. And this was received by Earl Bogosh, who is an orthopedic surgeon, and his vision for the chair includes a number of projects. One is a project in Whitehorse, the Yukon, which is in the far north of Canada. It has a very sparse population, and First Nations communities are highly represented in that area. He is also interested in funding other Canadian sites who have a motivated clinical team but no funding to start an FLS. And he is trying to fund these sites for 2 years, and then the hope is that the province will take over the funding of these FLS programs. And so he's currently in discussion with a number of sites in British Columbia, Newfoundland, Prince Edward Island, and New Brunswick. And part of the chair work hopefully will include linking our outcomes with administrative data, so we can look at some of these outcomes that are not captured by our FLS program, such as refracture rates and mortality rates. So in summary, I'd just like to say that the Canadian experience has shown us the importance of a number of things. It's shown us the importance of having an iterative improvement process. It's shown us the importance of being adaptable to local conditions, such as having a local champion at each of the sites that has an FLS. The coordinator FLS nurse role is very important in the success of the FLS. It's very critical that we have focused data collection so that we can evaluate the work that we're doing. And it's very important to consider patients' knowledge, perception, and attitudes. This has shown us that we need to radically revise our knowledge translation approaches and communication methods with patients. Hopefully, I've demonstrated that FLS programs have been shown to be cost-effective and cost-saving, and to achieve equity based on sex and age. All of these are great things to advocate for starting an FLS anywhere. However, we still have work to do, and one of the things we need to acknowledge is that the federal political structure of Canada, with its decentralization of healthcare management and finance to the different provinces and territories, is definitely a barrier to universal fracture prevention. So there's a lot of work to be done in that area. As I mentioned earlier, 89% of Canadians who fracture do not have access to an FLS, and we would really like to change that. And so our efforts are to expand FLS programs across the country. Thank you.